she had a TSH of 0.02. And so when she returned to clinic on November 30th of 2020, she had saw Dr. Hare, who was with, which she was the physician that I was working with originally. And she kind of went through a little bit more of her past medical history and noted that she had a history of ADHD that started in grade school, usually kind of around first grade. And then she was formally tested in third grade and in graduate school. And she was currently working as an astronomer at the Green Bank Observatory. And she said that, you know, she'd been using Adderall since she was very young, and she used it now because it kind of helped her pay attention in meetings now that everything was kind of online. But she said that, you know, it just helped her stay more organized. She kind of denied any issues with hyperactivity or interruptive behavior. And so during that first visit, she filled out the ADHD questionnaire, and Dr. Hare had ordered a thyroid ultrasound, some TPO antibodies, thyroglobulin antibody, and then her thyroxine total T4, a TSH, and free T3. So she kind of followed up on that TSH that had originally been low at the very first visit. She then returned to clinic on December 10th for the follow-up visit. She was diagnosed with Graves' disease from her labs, and then her Adderall was discontinued, and she was started on the methimazole, and she was referred to endocrinology at that point. She later returned like 2 weeks later, which was a follow-up for her thyroid ultrasound labs. And she was found to have 2 nodules on her ultrasound, one being a TR3, and she was advised that there was a possibility of needing a fine needle aspiration. And she said that the methimazole was helping her heart rate, but overall, she didn't really notice that much difference in how she felt. This patient was pretty bad about having regular meal times, and there were often times she would go throughout the day without really eating, and she would have like one meal. And she would snack. And so with this finish, she was Dr. Hare kind of counseled her on regular meal times and some of her dietary choices, because really at that point, her BMI was pretty low, and I'll kind of go through that later when her labs and stuff are coming up. And then again, she came back onto clinic on the of February 4th of 2021, and she had her endocrinology appointment she had her endocrinology appointment. Endocrinology did confirm that she had Graves. They increased her methimazole to 20 BID, and then she also had a Zoom follow-up with them since that time, and she had a full workup. She was supposed to have a full workup on 2/24 for some iodine scanning. She still said that she was pretty tachycardic. She had been gaining weight since the last visit, so she had gained 3 pounds. And she said that she had starting to feel better, but she was having some trouble because she was no longer on her Adderall for her ADHD, and she was applying for some jobs, and that was causing some severe issues with her concentrating at home. She had been working on having a better eating schedule, and propranolol on 10 milligrams BID was started on this visit. So the very last visit that I had saw this patient, it was 4/11/2021. She was feeling better. She was eating better. She had been following with her endocrinologist. She said she was doing well on her beta blocker. And then her endocrinologist actually placed her on atomoxetine 40 milligrams BID. And then as far as like some comorbidities, really, she just had the ADHD. She was pretty healthy. She was young, and this were her labs. On the first visit in August of 2020, it showed that her TSH was low at 0.02. Everything else looked okay as far as her cholesterol and her triglycerides and that. And then when she came back, I didn't really have any more notes from when she was seeing the previous physician at the clinic. So really, this was I only had her labs from that visit. But when she came back in November, you can see her weight. She was 111, but her BMI was 17.9. So she was pretty skinny. She was also pretty tachycardic. She was sitting at 115. And on physical exam, she was thin. She was kind of nervous. You could tell that she was kind of antsy being in the clinic. But she also had her thyroid was actually enlarged just from visualization. It felt normal, other than the fact that it wasn't large. Like you couldn't really feel any nodules or anything like that. And then with the follow-up of the orders that Dr. Hare had put in, it was actually found that her TPO antibodies were high at 252, and her thyroxine was 24.9, and it was pretty high as well. Her free T3 was 29.3. And at that visit, she was started on the methimazole, and she came in. She was still tachycardic from the visit on December, with her heart rate being 120. And her blood pressure was high on this visit, but generally it was not. Just the split visit, it was. She was still pretty thin. She was pretty nervous when coming into clinic. She was pretty upset with her diagnosis of Graves, and just kind of, she wasn't really expecting it at that point. Her thyroid was still pretty enlarged. I mean, you could see it. You could be sitting like in the same room with her, and you could notice that she did have a goiter. So, but as far as her heart rate, she was tachycardic, but S1, S2 was present. Everything else in her physical exam was normal. And most of these I just added in because I kind of wanted to follow her weight in this throughout the visits, because she was having some issues with gaining weight. And she, on her visit in December on the 31st, she dropped down to 110. Her BMI was 17.75. She still was a little tacky at 103. But then she was started, she went to her endocrinologist, she was started on some other medications. Her TSH was checked on the 31st, and it was 0.02. She came in February on the 4th, and she had gained a little bit of a weight. Her weight had been to 113. This is where she had gained some weight back, and her BMI was up to 18.24. And then her labs were again checked when she came into clinic, or before she came into clinic. She had her labs drawn on the 9th of March, and her TSH was still low at 0.02, but her thyroxine had went down to 1.8, and her free T3 had been down to 7.9. And then the very last visit that I saw her, she was actually up to, her heart rate was sitting normal at 74. Her blood pressure looked good. She had actually gained quite a bit of weight, and so she was sitting at a more normal BMI of 19.53. And at that point too, her thyroid was still enlarged, but it had been gotten smaller since the very first time she had came into clinic. It was soft on palpation. No nodules were appreciated when feeling. And then this was a list of her medications that she had been on, which was the very beginning. She was on the Adderall 20 milligrams PO, the methimazole that was started and increased to 20 milligrams BID, the propranolol 10 milligrams BID, and then the atomoxetine 40 milligrams BID that the endocrinologist had started with her. And so for some of the questions that I had from this case was, what does the lack of diagnosis of Graves compromise the efficacy of the treatment of ADHD? And also, are there any contraindications of using a stimulant as an ADHD treatment when having a comorbidity such as Graves? And what would be the best treatment option for treating someone with ADHD, while simultaneously kind of diving into this diagnosis that really she had no idea that she had. And lastly, one of the other questions I had were, what are some of hyperthyroidism's psychiatric presentations? Is there a better way to recognize them, to begin treatment earlier? Because, it's really unknown, because she moved here, of how long maybe she had been having issues with hyperthyroidism, but really it had gone untreated because most of her symptoms she thought were related to her ADHD, such as the nervousness and the tachy. She didn't know it was abnormal for her.
Thank you so much, Erin. That's a wonderful presentation with really excellent questions. So I will open up the floor for any comments or other questions they might have for you. And I'll keep these comments up just so they can kind of take that in and look at them as well for now.
Also, one other question I'd like to include, does a new diagnosis of hyperthyroidism always need to be referred to endocrinology?
Are you all waiting for the dentist to say something?
You are more than welcome if you like. But yeah, any feedback is welcome. Dr. G, did you have anything?
Yep, I was just patiently waiting to make sure we didn't get any more questions in the chat before I try to answer everybody's questions. I can start by answering that last question. You know, certainly not every case of hyperthyroidism needs to see an endocrinologist. And I think that the answer to that lies within the comfort of the provider, the nurse practitioner, the PA, or the physician. So no, they don't always need to see an endocrinologist. So I'll start by first just saying, Erin, you know, that was an incredible presentation. It was really detailed and thoughtful. So thank you so much for presenting for ECHO. Your presentations really make this program what it is. I think, you know, your participation is tremendous, and that was a great case. So I'll try to answer your questions to the best of my ability. So a lack of diagnosis of Graves' disease doesn't compromise the medication or the efficacy in treating ADHD, but I will tell you that having untreated hyperthyroidism will certainly exacerbate any medical condition, including ADHD. So with ADHD can certainly cause more agitation, anxiety, difficulty focusing. And you had mentioned that this patient had had an underlying diagnosis since very early in childhood. And so in these cases, if you have a patient that comes to you and says, you know, hey, Dr. Erin, I've been on medicine for my ADHD since childhood, and suddenly I can't focus, I can't concentrate, I'm agitated, I'm anxious. That should be your clicker that goes off in your brain and says, you know, maybe there's something else underlying that's contributing to the anxiety and agitation. So it doesn't affect the efficacy of the treatment that she's currently on, but it may exacerbate the underlying disease itself. So her treatment may need changed until we get the hyperthyroidism controlled, and I'll go through how we control that in a second. Did that answer your first question okay, Erin?
Yeah, it did.
Okay. So are there any contraindications of using a stimulant as ADHD treatment when having a comorbidity such as Graves' disease? So stimulants will worsen the symptoms because these patients, you know, think about your thyroid is your metabolism hormone. And so when we are hyperthyroid, too much thyroid hormone makes you feel anxious, agitated, nausea, vomiting, weight loss. It can even contribute to psychosis. I have seen patients who have thyroid storm who have to be admitted to an inpatient facility because of their thyroid. And once that's controlled, it certainly improves and gets better. But if you can avoid stimulants until the acute hyperthyroidism is treated, that would be ideal. But I think that really depends on how severe the ADHD has also been impacting, you know, her day-to-day focusing and routine. And so it doesn't necessarily mean that you need to avoid stimulants, but I think that it's something that you have to weigh the benefit and the risk. You know, does she truly need this stimulant for this 2-month period until we get her thyroid labs controlled? And that's usually how long it takes. Maybe not for complete control, but you can certainly gain with methimazole, even for a week, you can help symptomatic control, certainly. So no, it's not contraindicated, but if we can avoid it for those 2 months, it would be better. Which medication would be best treatment option for ADD? So that I wish I could answer, Erin. That's a little bit out of my scope. I don't treat ADD as underlying, as an endocrinologist. I don't treat it. So in those cases, I would really call and ask the person that's been treating the ADD, whether it's the primary or a psychologist or psychiatrist. And so it really warrants a team approach to it and seeing if there are truly other therapies to treat it. And excuse me, I did say ADHD. And then what are some hyperthyroidism psychiatric presentations? So I briefly mentioned that, but I caution people when they're hyperthyroid not to make any major life decisions. It can cause psychosis, agitation, anxiety, difficulty focusing, difficulty concentrating. It can be a temporary state of mania, if you will. So I really do caution against decision making until the thyroid is adequately controlled. How can we better recognize them so we can begin treatment for patients earlier? So I think understanding, the presentation of hyper and hypothyroidism as a medical student and a resident and attending is really important. And the symptoms of hyperthyroidism, as we discussed the psychosis that can occur and some of the mental symptoms, but also patients can have some of the things that you defined in your case report. So you can see a goiter. You do not always see a goiter. A goiter is simply just an enlarged thyroid gland. Not every patient that presents with Graves' disease has a goiter, but certainly you can have an enlarged, highly vascular gland that is a goiter. That would present with difficulty swallowing, voice changes, sleep apnea, especially new onset sleep apnea, and sometimes in a thinner patient. We see sleep apnea with certain neck circumferences, but if you see a very thin patient who has recently lost quite a bit of weight and they still have sleep apnea, that should be an alarm going off that potentially they have an obstruction at night while laying flat, and that obstruction can be their thyroid. A really simple test in the clinic that you can do is, have you been familiar, have you ever heard of Pemberton's sign?
I've never heard of it.
Okay. So Pemberton's sign isn't for hyperthyroidism. The only, it's for any enlarged thyroid gland or goiter. So it can be hypothyroidism, or just a goiter without thyroid dysfunction. And the way that we do that is we ask the patient to raise their hands over their head and hold it there. And if their face becomes red after 1 minute, we know that there's an obstruction. So the blood can't flow from superior to inferior, and it's being blocked off by their thyroid. And that's a positive Pemberton sign, and that's an emergency if you do see a patient that has a positive sign. Also, you can hear or even listen for stridor. Stridor is just kind of the wheeze that you'd hear if their airway is being compromised from an enlarged thyroid gland. These patients with hyperthyroidism can complain of, skipped heartbeats, racing heart, nausea, vomiting, diarrhea, weight loss. Hair and nail changes can be common. As a med student, resident, or an attending, it's really important to define hyperthyroidism first, and then define how bad is it? Do I need to send them to the hospital? So to do those two things, the first thing is what you did. You did thyroid labs. Overt hyperthyroidism means that their T4 and their T3 are high and their TSH is low. That's a biochemical diagnosis of hyperthyroidism. And then you want to use something called the Wartofsky Storm Score. That is very important because you're going to be encountering so many patients with hyperthyroidism, tons. About 1 in 100, 1 in 200 patients have hyperthyroidism. So you're going to see this a lot in your career. And, you're going to be faced with, do they need to go to the ICU and be admitted, or can I manage this with medicine? The answer to that is in the Wartofsky storm score. So the degree of how bad hyperthyroidism is a chart, the Wartofsky storm score. And are you familiar with UpToDate?
Yeah.
Okay. So I encourage you to bring up the Wartofsky storm score and UpToDate. It's a chart with a scoring system that gives you numbers associated with the symptoms that we discussed. So if they have nausea, vomiting, increased heart rate, depending on how high their heart rate is, you get higher points. That score will tell you how severe it is and if they need to go to the hospital and be admitted, if they truly are in thyroid storm. So that's how we diagnose it. And those are some of the symptoms that can be associated with hyperthyroidism. You didn't ask me about the treatments, but if you want, I can torture you with the different therapies that we have. I don't want to keep going. I know Dr. Boku has his presentation planned. But
That's not the problem. You made me smile and then my tooth showed.
There are lots of great topics on this particular case. You know, how do we treat hyperthyroidism? There's many treatments other than methimazole that we use. And then the other question is, she's 38. So we always, in every single female that's childbearing age, I don't care what condition you're talking about, we have to always consider pregnancy. And that's no different in hyperthyroidism. And so the drugs that we use to treat hyperthyroidism are different if a female is pregnant or if they're considering pregnancy. And our therapies to treat hyperthyroidism are also very different depending on if that woman is planning to conceive. So it's always a good question in a female to make sure that you ask if they're pregnant, or doing an HCG, and if they're unsure, you know, the HCG, or asking them if they plan to become pregnant in the next 1 year. That impacts our therapies. So I won't keep going on, Erin, unless you want to talk about that further. I don't want to detract time from Dr. Boku, so.
And you can also, if you have like a quick write-up and you want me to send it over to Erin, I'd be happy to do that as well if you have the time, Dr. Giordano. You're so great to have on our talks. Thank you so much for all your intellect. Really appreciate it. Erin, are you okay with that answer?
Yeah, absolutely. Like, that was really helpful, and I appreciate everything that you said.
Great. Thank you so much. Yeah, just for the interest of time, this is a really interesting one. So really great presentation. I really appreciate you taking the time to do so. All right, Dr. Boko, I'll pull up your presentation. Just give me one moment, please.
Okay, well, I was asked to talk about oral manifestations of endocrine disorders, and believe it or not, I've given half-day seminars, continuing education seminars on the topic. So to get it down to this short time period might be a little tough, but I'll do my best.
You're right.
I picked the ones that seem to produce the most problems for us. And if you could, Mitra, are you the one, or Elizabeth, are you the one I asked? Okay, Elizabeth, if you could hit that start of lecture button. And then next slide. This is talking about estrogen effects in the mouth, and you probably wouldn't know it being physicians, but we look a little more carefully in the mouth, and we can almost tell if somebody's pregnant if they've been our patient. And I have dental students and myself a couple of times have told somebody they better go get tested, because one of the facts about estrogen was, I'll show in the next slide, but the cells of the gingival tissues actually have one of the highest number per acre of estrogen receptors in the body. And that was found right here at WVU. But so the gums are very much involved, and of course dentists are tuned to gum problems and changes. But another interesting thing about estrogen is we have this thing, pyogenic granulomas, are formed anywhere in the body. Sometimes they're called a little different variation of a hemangioma by our dermatology friends, but the very first in the mouth, they've always been called pregnancy tumors because they develop so well in women who are pregnant. And the very first example of a pregnancy tumor, and therefore the first example of a pyogenic granuloma, is in this picture from 1839. And this fellow was from West Virginia, although at the time it was Virginia. He's from the Wheeling area. And he went on to do so much good that about 30 years ago, the oral surgeons in this country got him to be recognized as the father of oral surgery. Simon P. Hullion is what his name was, and this is his drawing. He drew the picture, and this was a little 18-year-old girl. Back then, they put the patient's name and everything, where she worked in the journal articles. But she came in pregnant and had this mass, and he was going to remove it, and she said, no, I don't want to remove it. So she had her baby, and it went away almost completely. And then she had the next baby, and the same thing happened, and it went away. And she had the third baby, and the same thing happened. So the diagnosis, even though we don't have histology, is really clear. And this is 50 years before any dermatologists even mentioned a pyogenic granuloma. So it's really a very innovative and kind of trend-setting idea for dentistry. We're very, very much used to pyogenic granulomas. Next, please. And we have also something else that's kind of unique relative to a lot of the pregnancy-related things, but in the saliva, we have a lot of, every time I look at a pap smear with salivary flow a little bit around the cells, there are always a bunch of neutrophils, even in somebody who doesn't have acute gingival problems. It's just part of the saliva. And our salivary glands, there have been studies that have found over 50 different, or 5,000, I'm sorry, different proteins and cytokines, different molecules in the saliva. And dentistry right now is working hard to try to identify. The salivary glands just seem to be able to mimic all of that and then put those proteins into the saliva that goes into the mouth. And we're trying to identify that. We probably have 20 or 30 diseases we think we can actually diagnose by salivary proteins. So that's still down the pike a little bit, but we do have in pregnancy, we have quite a few different changes in the cellular and molecular structure of the saliva. So that's an important change. Maybe that's why people get something called pregnancy gingivitis. Somebody who has really good oral hygiene and doesn't have any red gums, when they get pregnant, they don't get this. But if somebody does not brush their teeth well or frequently, and they have kind of puffy red gums, even though they're a little bit, even though they're fairly young, those gingival tissues just puff up like crazy. And sometimes they almost cover the front of the teeth. So pregnancy gingivitis is a name, a really old name, and we still use it because it seems to fit. We don't have an abrupt onset gingivitis outside of pregnancy or puberty sometimes. And it doesn't really cause destruction of the underlying bone because it doesn't last that long, but it can if it goes on. So we've been telling people forever, brush your teeth really well before you get pregnant and while you're pregnant. Also, we have these changes in the saliva that we see in pregnancy. It starts in the very beginning of pregnancy, and then it all peaks. And pregnancy gingivitis peaks right in the middle in the second trimester. And by the third trimester, it doesn't get any better, and it might actually get, it doesn't get any worse, but it might actually get a little better. So usually it disappears entirely after birth. That's the main estrogen-related oral manifestation. And we have lots of studies now that have shown, we want to say cause and effect, but we really don't know. But women who are pregnant and they have a higher gingival inflammation index, there's a really strong association with early babies being born with preeclampsia, and also low birth weight babies. And the amniotic fluid is supposed to be sterile, but about 2 or 3 years ago, they found the first 2 living bacteria in the amniotic fluid. It was printed up, and they were both gingival bacteria. So Porphyromonas gingivalis has been found in all kinds of other things. Most recently, it's found in the plaques of people with Alzheimer's. So this, the whole gingival rest of the body connection is really a strong focus of study in the dental profession. Next, please. And I don't want to get into the histology, but it's just granulation tissue, these pyogenic granulomas or the gingival hyperplasia. But we have so many bugs in the, it's actually become a full profession of people studying the microbiome of the oral cavity. Mostly they mean the gingival areas. And we have a lot of studies that have shown that when somebody has a lot of bacteria, different types of bacteria, not just numbers, when they're pregnant, they are going to be more prone to having all of these issues, not just the pregnancy gingivitis, but low birth weight baby and things of that nature. And I said we're very used to pyogenic granulomas. 75% of them are right there in the gingival tissues. And that's regardless of whether somebody's pregnant or not. They're probably higher. Probably all of them, and somebody who's pregnant would be on the gingival tissues. So it's a pretty significant effect on the mouth, and it's easy enough to take care of. Most dentists recognize it. The problem with pyogenic granulomas is they look a lot like oral cancers. So if a dentist is going to be hard pressed to wait around 4 or 5 months in order to not to make the final diagnosis. But a lot of times we are doing that. Next, please. There's another thing, by the way. It's like a pyogenic granuloma, but it's from the cells that make up that ligament that holds the tooth in place, the periodontal ligament. And that those ligament cells have the ability to make bone as well as other things. So we may see a bunch of bone, as we see in that lower picture, within this gingival mass. And so it's the same as a pyogenic granuloma, but a little different structure. And these can get to be massive, and these can push the teeth out of the way. And they have a lot of estrogen receptors as well. So it's a little more serious than a pyogenic granuloma. But even these, we usually let go until we see what happens after the baby's born. Next, please. Oh, I forgot to put a new picture on there. So let's look at insulin. I'm diabetic myself, so next, please. I have a firsthand understanding of this particular disease, but in the mouth, you can imagine, because the teeth are so sharp and they're right there, and there are lots of rounded, flexible, floppy-like structures around them, that we bite ourselves pretty well and pretty frequently. And I have been truly amazed that we almost never see traumatic ulcers when somebody comes to a dentist. People have histories of them, they remember them, but they don't remember them very long. And they are very common, but if you just look at a bunch of people all at once, you won't find them in the top 10 lesions. You'll probably find canker sores at a higher rate. But nevertheless, if you're diabetic and you have a traumatic ulcer, especially if you're older, you have a dry mouth, you wear dentures, they get a little bit loose as the bone underneath wears down and remodels, and we get ulcers that can last for months and sometimes even years. And we may end up, a lot of them have this little rolled border around them, so it looks like a cancer of the mouth. So we may end up doing a biopsy, but most of the time we can kind of tell as dentists which ones are ulcers and which ones are cancers. The cancers develop much, much more slowly, but it's just we get a feel for it because dentures produce so many ulcers. But if you're diabetic, it may take 3, 4, 5 months for that ulcer to heal. So we've learned to just tell people, even with diabetes, that you can leave your denture in, and the saliva is very protective. And we almost never will have any kind of a massive inflammation or infection, destruction and inflammation of the underlying bone. It's just a local ulcer, and as time goes on, it gets a little bit of a scab, pretty thick on the surface, and it doesn't even hurt that much. So diabetics do delay the healing, but nothing much beyond that. I had somebody who had an ulcer on the hard palate. He came in and there was no inflammatory response. That picture you see on the bottom left, you see there's no redness around it. And in the mouth, almost always when you have a traumatic ulcer, there's a red halo around it. And diabetics don't get that. And so we know that the inflammatory response is minimized. But the patient I alluded to earlier, he had an ulcer about the same size as what you see on the lower left, and but it was on the hard palate, and he said it had been there for about 4 months. And before I took a biopsy, I sent the patient off for blood studies, and I think his sugar levels were somewhere around 500 or 600. And that was the first sign that he had diabetes. And in my career, I've seen maybe 14, 16,000 adults with mouth issues. I'm an oral pathologist, so I don't work with teeth all that much. I would say probably the traumatic ulcers that I've seen have probably 70% of them have been diabetics. And the very first time that they knew that they were diabetic. We also have other things. Recently, some of my students wrote a paper, did a lit review on residual sockets. Do diabetics heal after extraction of third molars? And most of the time they heal just fine. Every once in a while it will go bad. And sometimes if we take an x-ray of somebody who was diabetic early on when the teeth were removed, we can see the outline of the socket many, many decades later. And then if we have a response, we might get one of those pyogenic granulomas growing right out of the socket. The old guys used to call it epulous granulomatosum. And that's more likely in diabetics, but it's not a big deal. You just curate it out and leave it at that. But mostly diabetics are prone to gingivitis, periodontitis, and loss of teeth because of bone loss from the periodontitis. Next, please. Corticosteroids, next, please. We have too much and we have too little. When we have Addisons disease, we don't have enough. And what happens is the pituitary gland tries to stimulate a little bit more, and it doesn't work very well. So we get a lot of melanin stimulating hormone in the body, and the mouth has very little pigment, even unless you have dark skin. And that pigmentation starts as a child. But if you have pigmented spots, as we see on the right, or the left, I'm sorry, then you probably, the first question a dentist is going to ask is, when did you start developing those? And if it was childhood, then we'll say it's probably racial pigmentation. But if it's in older people, then Addisons disease, if there are multiple ones, are the very first, that's first disease we even think of. We have to biopsy it to make sure that it's not a dysplastic or melanotic melanoma type of a lesion. But after that, then it's off to you guys to be treated. And but with Addisons disease, we get sometimes a super dry mouth, and whenever we get a dry mouth, candidiasis is about 40 or 50% of us have candida spores in our mouths all the time. So in that group of people, once the mouth dries out, that candida goes into the hyphae or disease-producing state. And of course, it turns out that we even have a disease with candida and polyendocrine disorders. So the dentists are well aware of that, and they're also well aware of candida and what it normally, we call it a red flag disease. It'll tell us that this patient has something going on above and beyond the mouth problems. Next, please. Next. There we go. And with Cushing's, whoop, a little bit, can we go back one? With Cushing's, where we have just the opposite, we have dentists use a lot of corticosteroids, of course, for treatments, but that also produces a pretty strong xerostomia. And whether somebody has a dry mouth or not, if they have too much cortisol, too much, whether it's from medication or from the adrenals, this is going to stimulate candida. It's not quite guaranteed, but it comes close to being guaranteed. And also the immune response that normally keeps your gingival infection under control is going to be diminished. And so if you happen to be somebody who doesn't take care of their teeth very well, then you can end up with gingivitis or worse gingivitis that you had before. And also somebody might come in, this is usually in young adults and even teenagers, that top left picture, perioral dermatitis, they come in and they've got acne around them. And it's actually kind of a combination of acne and folliculitis, and the dermatologists just call it perioral dermatitis. It is also something seen in somebody who's given pretty high doses of corticosteroids for a fairly long period of time. And people do bruise more easily in this disease, but we don't see a lot of that in the mouth. And of course, if they get a traumatic ulcer, they're going to have the diabetic issue of poor healing. It'll take a long time, but it won't be worse. It's just more duration. Next, please. Next, please. I'm out of time, right? Have I still got time? Oh, okay.
You still have 10 minutes.
Oh, all right. With the thyroid, we have the same issue. Sometimes you have too much, sometimes you have too little. Most of the time, at least in this country, we've got too little. And we can tell that because the tongue gets puffy and the mouth gets dry, and things happen in the nostrils as well. So people start breathing through their mouth, and that dries the mouth out more than anything else, and will even give a little bit of redness to the gums, gingivitis, to the anterior area, because the air is passing over, especially those upper teeth. The lips can get enlarged as well, and we are seeing more and more of that now. It happens to be secondary to injecting different materials into the lips, so they look more beautiful, I guess. But macrocylia without that kind of a habit is probably the first thing we would think of if it's a relatively adult onset type of thing, would be hypothyroidism. And we see patients on a 6 month, we try to see them every 6 months, 12 months at the most. And at least according to surveys that I have read, dentistry does a much better job than medicine in that regard. Almost everybody, about 80% of the people in Morgantown, for example, see a dentist every 6 months. So that's, it's a nice place for things to be noticed at an early stage. And of course, we tell our dental colleagues that all the time because we want to find cancers at the earliest stage, but they're well aware of these kinds of changes too. Any kind of swelling of the face without swelling of the rest of the body, or the voice. We're used to seeing people and you wouldn't think you'd get to know them, but you really get to know your patients, even though you only see them once every 6 months. And at least my colleagues who have these recall systems tell me they can pick up on a sound of the voice change, and they're mostly trying to pick up a voice change to tell if somebody has been using crack cocaine or marijuana. And so, because that's going to make a difference in how they react to certain dental procedures. But they know about hypothyroidism as well. If it is in a very, very young person, the teeth may not erupt. And I had one patient from the WVU hospital, wasn't a dental school patient, who had no teeth. They never came in. The patient was about 6 years old and there wasn't a single tooth that had erupted. And it turned out it was a very low thyroid hormone level that did it. Tooth formation in this also, as you would kind of expect, can be impaired. So a tooth that not only won't erupt, but if you look at it, it could be years behind in the development of the crown and the root structure. And of course, you know how dramatic it can be. That picture is off the internet down below, but treatment is a big help in somebody who has a puffy face. Next, please. And of course, it is part of it's a legal responsibility of dentists now. It has been for about 30 years to palpate the neck and feel any kind of neck masses. And we sold it, those in my profession, oral pathology, sold it to the general dentist as a way to pick up on metastatic cancers, because about 40% of people with mouth cancer were coming in at diagnosis already with a neck node. And that just didn't make sense. So that's what they're doing now, but they're going to be picking up on thyroid. That's part of their realm. They might not make a diagnosis, but they should be referring anything that's abnormal. Sometimes with Graves' disease, we get not only in somebody who's got that hyperactive muscle problem, the muscles of the face can cause clenching. They just feel better when they're clenching and tightening their teeth. They may grind their teeth back and forth, so a dentist can pick up on, we call that abrasion, abnormal wear and tear. And we can pick up on that, and we know how much wear and tear teeth should have at different decades of life. That would be pretty serious for somebody to have atrophy of the tongue. And that mostly, when we have atrophy of the tongue, it's some kind of an inherited syndrome. So they had a small tongue from the beginning, and it's really not atrophy, developmental atrophy, it's more embryologic type of atrophy. But some people will have problems with the trigeminal nerve, and the signal gets cut off to the tongue, and half of the tongue will be atrophic. But in Graves' disease, it's bilateral. And of course, the exophthalmos is pretty common. That's kind of the standard classic feature. Facial flushing, I get that because I've got a mostly Swedish background, but I guess maybe I've got eternal Graves' disease. Burning mouth syndrome is the bane of the oral pathology world. About 1/4 of all my patients over the years have burning mouth syndrome. And usually I can figure out they've got a vitamin B12 or B6 deficiency, sometimes an iron deficiency. And we always send off for thyroid hormone levels. But after that, we still have a whole lot of people. I'd say 40% of all the people I saw with this, I could not figure out the cause. And there is a strong psychosomatic focus to burning mouth. I don't know if it's real, or most of those papers were done back when the doctors are all men and the patients with this disease are usually all women. So we'll have to wait till we get some female docs looking at this a little differently. The thyroid can be enlarged, but doesn't have to be enlarged, as you know. So we may pick up, it should be enlarged, sorry. And in addition to the thyroid, the stimulus, the hormonal stimulus also can cause the tonsils to enlarge. And this is a chronic hyperplasia. And I had one Graves' disease patient where the first sign that they had this disease was tonsillar hyperplasia, bilateral, and the tonsils were so large that they literally touched each other. And yet the patient was not aware of the fact that they had large tonsils. That was a teenager. So I don't know how you can have tonsils that large and still swallow food and talk without any problem, but that person was able to do that. And we can also have premature eruption, just as we had with the hypothyroidism, we had no eruption or delayed eruption. We have premature eruption of teeth, and I should have put down premature development of the teeth as well. Next, please. Parathyroids. I don't know how often, next please, you get into parathyroid problems, but dentists deal with teeth and they take x-rays on everybody. So we pick up parathyroid problems from time to time because of abnormal x-rays. There is, in the facial area, there is a Chvostek sign. I've never heard anybody else pronounce it, so I may be saying it wrong. But the upper lip kind of twitches backwards when you tap on the side of the face. So I don't think that's used very often in dentistry, but it is one of the signs of hypoparathyroidism. And it's just a sign of a kind of a mild sign of tetany. Mostly if somebody has a hypoparathyroidism, they're coming to the dentist because their mouth, their lips feel numb, the tip of their tongue feels numb. And it feels as if, they always tell us, it feels like you gave me a local anesthesia. excuse me, and because they also have difficulty swallowing because of the muscle, the tetany issue. And that doesn't have to be a very strong issue to get that swallowing problem. If somebody has this from development of the teeth at that young age, you can have failure of tooth eruption, just like with the low thyroid problem. But the biggest thing that we see in dentistry is enamel. Enamel is very, very susceptible to mild abnormalities in their environment. And enamel, if you look at that lower picture, enamel forms along the top edge, the biting surface of the front teeth. And then each enamel ameloblast that makes the enamel just makes a very slow line straight down to the gums. And so we have patterns where some people will have good enamel and then right next to it there'll be bad enamel, and those are vertical patterns. In a disease like hypoparathyroidism, the hormone problems apparently aren't consistent. So we see horizontal places where probably the hormone issue was more severe and the enamel was most affected. And you see several different areas of involvement there. So we do have at least several manifestations in and around the mouth for hypoparathyroidism. And of course, these people are also prone to candidiasis with the polyendocrinopathy. Next, please. You can also have very generalized enamel hypoplasia. So it looks like the teeth are super yellow because the enamel is so thin that you're looking at the dentin underneath, and that's a yellow color. Also, some people will, not too often, but it does happen. It's if we see a pulp chamber that's really larger than normal, we will, this is one of the diseases we think about, and we get little calcifications inside the pulp. They're often dagger shaped, they're kind of pointed up and down, and that picture didn't come out very well, so I apologize for that. Oligodontia is our word for just not enough teeth. They didn't develop at all. Not that they didn't come in, but they didn't develop at all. So this is one of those entities that produces diminished numbers of tooth development, of teeth developing. There can be delayed eruption, and that's what the lower x-ray on the left is showing a premolar or bicuspid. The root should be about the same width or same length as the molar right next to it, but it's very short. And that can be just routine random event, but we have to rule out pseudohypoparathyroidism. I forgot to mention that the pseudohypoparathyroidism has these particular features, not so much, more so than the hypoparathyroidism. And we also have people with this, the middle of their face just doesn't develop very much. So it looks like it's been pushed in. And from the side, they'll have this very flat facial feature. And we just call it midfacial hypoplasia. And when that happens, the teeth you see on the lower picture on the right, the teeth don't come together, even though the posterior teeth are touching, the front ones are not touching. And we call that an anterior open bite, and that can be adjusted with orthodontics, but it is one of the things that's seen in pseudohyperparathyroidism. It's hard to say that word with a tooth missing. And then, of course, we don't take skull views very often, but orthodontists do, and they always do in their patients, and they can pick up a really thick skull. And there are maybe a dozen types of diseases that will present that way, and this is one of those. Next, please.
I hate to cut you off. I feel so bad, but we are at our time.
Okay.
But is excellent so far, and I will have this whole presentation sent in the recap as well. But if anybody has any quick questions or any comments.
Just that was a wonderful presentation, Dr. Bocco, and we always love having guest speakers, and you're always welcome to come back, finish that as a part 2 if you'd like. We are in the process of our curriculum development, so if you're available for the second half of this year, we would love to have you back. Thank you.
I'm retired. I do what I feel like doing, so that's fine with me.
Excellent. We would love that. Thank Thank you so much. We really
Okay.
appreciate your time today. I just have
And by
one
the way,
announcement.
I never finish my lectures. I'm always cut off short.
It's okay.
So don't feel
I can
bad.
talk forever as well. Like I tell people, please tell me, stop talking. Like I can talk and talk and talk. So I understand, especially when you're passionate about something, you know. just
Okay.
something that you can see it. But our next session will be on May the 12th, and Dr. Jennifer Giordano will be discussing chronic kidney disease that day. So again, thank you, Erin, and thank you, Dr. Boko. Really appreciate your
Okay.
time. Everybody
Goodbye,
have a
all.
wonderful day.
Thank you.
Bye-bye.
Thank you all so much.